Dr. Joydeep Ghosh, he will speak on the management of the colon cancer. As we all know that colon cancer is now is not that rare. The invent of the colonoscopy, we get a lot of cases, and I think Dr. Ghosh will be the right person to speak on the colon cancer prognosis and how it will.
Thank you, sir. Thank you, IMA South Kolkata, for inviting me for this session. I have kept my talk as basic as possible so that I do more of talking and less of you seeing the screen. And I'm of course open to any kind of questions that comes up at the end of the discussion. So I'll just go through about few initial basic topics about colon cancer. So to start off with, if you look at the recent epidemiology of colon cancer, the GloboCan is the association which looks at the global epidemiology of all cancers. So from the GloboCan 2022 data, which was the last data that was published, you can see that colorectal cancer basically forms the third highest as far as new cases and deaths are concerned. This was not there before, primarily because colorectal cancer, the risk factors of colorectal cancer are more urban and more lifestyle related. So with the improvement of lifestyle as a whole in the population, the incidence of colon cancer has increased. And also, this incidence of colon cancer is appearing to be increased because there is higher awareness about colon cancer. Many people in the Western population, they are going for colon cancer screening. So these are getting detected early, and the more we are aware of the symptoms, the more it gets detected. So if you look at the standard risk factors for colon cancer, obviously age, because it is an age of the slightly elder population, being older than 50 years, use of alcohol and tobacco, just like any other cancers, low fiber diet, because long-standing constipation, low fiber diet, and change in the gut microbiome also contributes to development of colon cancer. If there is a family history of colon cancer, now sometimes we tend to confuse family history in the sense that somebody who is having any form of cancer in the family, we tend to take that, okay, my mother and father had cancer, so I'm supposed to have cancer. Cancers do not inherit like that. The familial cancers have a clustering in the family. Like, for example, if I have 2 or 3 colon cancers in my family, then I have a higher chance of developing colon cancer. But it's not like my uncle has got lung cancer, my aunt has got head neck cancer, and somebody has ovarian cancer, so I will have some form of cancer. So the cancers are very heterogeneous thing. They are not a single disease. They are not transmitted by a single gene. There are specific genes which are associated with specific cancers, and more so, the genetic inheritance of cancer is actually very rare. If you see the contribution of genetics in developing cancer in a particular patient, most of the times it will be less than 5% or max to max 5 to 10%. Majority of the cancers develop sporadically due to either presence of risk factors or even in the absence of risk factors, and a small percentage develops because of genetics. Also, if there is a prior history of inflammatory bowel disease like ulcerative colitis, somebody who has got uncontrolled ulcerative colitis for a very long time, what happens is in the gut mucosa there is a chronic inflammation. So whenever there is a chronic inflammation for a very long time, that is an ideal, you would say, that is an ideal platform to develop abnormal mutations which can turn cancer. So any kind of chronic inflammation, even if it is in the colon, in the form of ulcerative colitis or Crohn's disease, can lead to malignancy transformation at a later stage. Lack of physical exercise, again that leads to obesity. Obesity in turn is a risk factor for colon cancer. So these are the most common identifiable risk factors for colon cancer. Not necessary that if somebody develops colon cancer, they have to have one of these, otherwise it is not possible. It is not like that. Even somebody who is very fit can have colorectal cancer even without any of these risk factors. So how does it develop? So primarily the colonic mucosa shifts from normal morphology to an adenomatous polypoid morphology with the accumulation of certain mutations which are not in our hands. and those mutations, if they keep on happening unabated, they finally lead to colorectal cancer. And the timeline of this carcinogenesis is so slow that it can be almost up to 10 years, that for a normal mucosa to become purely cancerous or form a proper cancer, it can take up to 10 years. So we have a long opportunity here to detect early and take action so that we don't land up here. Now, if you look at the stage distribution, fortunately 80% of colorectal cancer patients develop at an early stage and 20% develop at a later stage. Now, why they present at an early stage? Because I'll come to the clinical manifestation. So any cancer which has got symptoms which occur very early in the disease pathogenesis, they are the ones which get detected earlier. But in the contrary, suppose you take up lung cancer, since lung is a very expandable organ, so a mass developing in the lung takes a lot of time to expand and cause symptoms. So that's the reason why lung cancer patients have a delayed presentation. But on the other hand, since colon cancer patients have symptoms, they usually take medical opinion and they are detected earlier. Coming to clinical manifestations. Now, when it comes to clinical manifestations of colorectal cancer, rather symptoms, we tend to divide the symptoms into two types. One is those when the colon cancer develops on the right side, like the ascending colon or the proximal part of the transverse colon. Now, here the stool is not exactly formed solid, it is more liquid on the right side. So you do not get those typical obstructive symptoms on the right side. But what happens is, whenever there is a right-sided tumor, there is a chronic blood loss that happens into the colon. That leads to anemia, because many times older patients who have been worked up for anemia without any other reason was found to have colorectal cancer with the colonoscopy, because the stool for occult blood came positive. That started the investigation of colonoscopy and was found to have a cancer. Sometimes if it is undetected or the anemia does not happen, it can form a lump, especially if it is more on the serosal side rather than on the more luminal side. And of course, abdominal pain, because if it involves the posterior part of the ascending colon, there are nerve fibers exiting, so that can be compressed and lead to abdominal pain. On the other hand, the left-sided tumors have a slightly different symptomatology, because in the left side we all know that the stools are formed. So if there is an obstruction or if there is a mass, there will be obstruction. So patients can present with bowel obstruction, they can land up in the emergency with large dilated bowel. They can have bleeding because the stools are formed, so when they pass, they get stained by the blood. And of course, altered bowel habit. Somebody who was having a normal stool habit, suddenly the stool habit has changed. There is increase in the frequency, or the stools have become more narrower. Those are the symptoms that should not be taken lightly, because those can be the early symptoms of colorectal cancer. And be it right side or left side, if it is advanced disease, means it has spread outside the colon to the other organs, we will have abdominal distension, weight loss and anorexia, which are very common symptoms of any advanced malignancy. Now, when we are faced with a patient where the symptomatology is fitting in with a possible colorectal cancer, what are the investigations that we need to do as a patient? So in the CBC, we all doing a CBC and a biochemistry profile. So in the CBC, we need to look for whether the patient has got iron deficiency anemia. Because somebody who is an elderly male or an elderly female, more of an elderly male, who has sudden onset iron deficiency anemia, there can be most important two reasons. Either it's a bone marrow problem or there is a blood loss problem. And more commonly, it's a blood loss problem rather than a bone marrow problem. Because if you see in the CBC that all the cell lines are okay, only the hemoglobin is down, and also the RBCs are microcytic hypochromics. That means that there is a chronic blood loss that is happening, and most common area of chronic blood loss is the gut. So iron deficiency anemia is something that we need to look for in the CBC. Of course, if we are suspecting colon cancer, a colonoscopy should be done. And in colonoscopy, what are the things that we look for? We look for the location, whether it is a left-sided or in the right side. Whether the scope can be passed, because this is very important. Sometimes what happens is the scope is not passed or that comment is not made. Now this is important because for oncologists like us, we need to, if the scope cannot be passed, that means the patient has got an impending obstruction. And in those situations, we might have to do a diversion stoma before we start any treatment. So this comment is also very important, that whether the scope can be passed. And obviously, if you have a mass visible in the scopy, you obviously get a proper biopsy with multiple cores, because nowadays we are in the era of targeted therapy, so we will need the larger amount of tissue to do the molecular analysis and plan the treatment accordingly. Tumor markers, well, there is no role of doing a horde of tumor markers. The more specific one is the CEA, but not necessarily that CEA will always be elevated. And also, an elevated CEA is not a diagnosis of colon cancer, because CEA is very non-specific and relatively less sensitive, but it helps or supports the diagnosis of colon cancer. And sometimes, how CEA helps is that if the CEA is very high in an early colon cancer, that means it portends a poor prognosis. So it has got a prognostic implication in an early colon cancer patient. And when we diagnose that it is probably a colon cancer with a colonoscopy and biopsy, obviously the next step as an oncologist would be to stage the cancer, whether it is restricted to the colon, whether it has got to the regional lymph nodes, or whether it has got to the distant organs. Now there are three ways to stage. We can go for the conventional CT scan, we can go for PET scan, and very recent update, we can go for something called a modification of PET scan, which is FAPI PET scan. Now I'll show you why FAPI PET will probably be the investigation of choice in future for colorectal cancer. This is the image of normal PET scan, which we all are doing nowadays. So here you can see that there is not much of a disease anywhere. These are all uptakes in the kidney, so this is physiological, but there is nothing visible here. Just the small uptake here, so it's basically the junction of the transverse and the descending colon. A small flimsy uptake you can see here. But this patient, when was taken up for FAPI PET, look at this, extensive from neck, lung nodules, omental nodules, so it's basically metastatic disease. So the whole treatment will change. If we go by this, we will try to operate the patient, take him up for surgery. But if we have this picture, obviously operation goes out of question and the patient goes for systemic chemotherapy. So this is the reason why probably in the future FAPI PET is going to take over normal PET CT when it comes to colon cancer, but not other cancers. Now coming to biopsy. Now we all know that biopsy forms an integral part of cancer diagnosis and treatment. Now what are the things that we need to have in the biopsy report? First is type of the cancer. Most commonly, 99% of the time it will be adenocarcinoma, 1% of the time it can be some abnormal squamous cell carcinoma, something like that, but largely it is adenocarcinoma. Second is grade, whether it is grade 1, grade 2 or grade 3, because this helps us, the medical oncologist, to decide the treatment later on. Third is molecular markers. So this is a recent update because it has seen that patients who have this molecular marker called microsatellite instability, or MSI in short, they have a difference in outcome, and also the treatment also differs. And also HER2 is a marker that we need to do, because now there are targeted therapies against HER2, so we will have those advantages if we know this marker. And next is next generation sequencing, which is coming up in a big way, not just in colon cancer, for most of the cancers, because the newer generation is trying to look at what exactly is the driver mutation and try to hit that mutation rather than carpet bombing with chemotherapy. So in NGS we look for these mutations, RAS, BRAF. It is largely used as of now for metastatic cancer. It is not useful in early cases. It helps in deciding the treatment or the regimen for metastatic cancer. So it is not as of now recommended in the early stages, but in the metastatic stage. Now how to work up? So we go for staging, scan, preferably a CT or a PET CT, and even better a FAPI PET if you have the finances or the setup. Histopathological confirmation, definitely mandatory for all patients. A baseline CEA level, this again has got a prognostic implication. So these three are required for the oncologist to decide what should be the treatment of this patient. Now, how the treatment decision is made? Ideally, it should be made in a multidisciplinary meeting where all these specialties are present and the patient is discussed, because colon cancer treatment involves the role of surgical oncologist, medical oncologist, not much of a radiation oncologist, pathologist, radiologist definitely, and especially somebody who has got a stoma care nurse should also be there with the team. Now coming to the treatment proper. So I'll first discuss the early stage. Early stage basically means when the colon cancer is restricted only to the colon, or it has spread maximally to the surrounding draining lymph nodes and not to any distant organ. So in that situation, surgery is the mainstay of treatment. So if it is a right-sided colon cancer, a right hemicolectomy. If it's a left-sided colon cancer, left hemicolectomy. And if it is a transverse colon cancer, then an extended right hemicolectomy is the surgery of choice. And when the surgeon is going for hemicolectomy, these three things should be kept in mind. It should be an en bloc resection and not a piecemeal resection. Because if you make it piecemeal, you are upstaging the cancer and the prognosis goes down significantly. So an en bloc resection, preferably you clamp the supplying mesenteric artery and then take up the patient for resection. A 5 centimeter margin is recommended of normal bowel tissue, and a complete lymph node dissection. Now this is something that we commonly face in our practice, is that patients of colon cancer comes to us, surgery done of the primary, but only 2 lymph nodes taken out. Now when you are taking out less than 12 nodes, that itself is a high risk for recurrence because you are not doing an adequate sampling. So we do not know that in the rest of the nodes the metastasis has not gone. So the treatment changes. So definitely for that reason, at least 12 nodes should be taken out when you are going in. And if you can take out more, even that's better. Now once the surgery is done, the adjuvant treatment has to be given. Now what kind of adjuvant? There is no role of any radiotherapy because we are talking of colon cancer. Rectal cancer is different, that's a different disease. I will not discuss rectal cancer here. So in colon cancer, there is no role of radiotherapy after the surgery. Adjuvant chemotherapy is required in majority of the cases. And what adjuvant? For stage 2, single agent capecitabine is the most common agent that we use. And for stage 3, it is either a combination of capecitabine plus oxaliplatin or modified FOLFOX regimen, which is 5-FU plus leucovorin plus oxaliplatin. So any of these agents can be used. Capox can be given on a more easier fashion. It's a 3-weekly dosing. Patient takes the tablet, doesn't have to stay in the hospital, doesn't need a central line. But for FOLFOX, you need a central line. The patient has to stay for longer time in the hospital. But the disadvantage is that Capox is more toxic when it comes to diarrhea and all those things, but FOLFOX is relatively more tolerated. Now what are the indications of adjuvant treatment? Any node positive disease should get adjuvant treatment. And if it is node negative, and if it is T3, the TNM staging that pathologists use, if it is T3 with high risk features, what are the high risk features? Patient presented with obstruction. Patient has a very high CA level. The biopsy shows poorly differentiated carcinoma. There is a lot of LVI, PNI in the biopsy report. These are the high risk features. So if these high risk features are present, in that situation we need chemotherapy. Now where can we avoid chemotherapy? Somebody who has got a T3 lesion, but there are no high risk features, and the molecular test shows that it is MSI high. MSI comes as either high, low or stable. So if it is MSI high, no risk features, T3, there is no role of any adjuvant chemotherapy. But all other patients will require adjuvant chemotherapy. And when it comes to the regimen, as I told you, for stage 3, either Capox or FOLFOX is the regimen, and it is usually given for 6 months in most of the cases. And there are certain studies which have shown, large studies basically involving thousands of patients, where they looked at whether a shorter interval like 3 months is as good as 6 months. And in those trials, it was seen that patients who have a T3N1 disease, that is early stage 3 disease, in those situations, 3 months of chemotherapy is good enough. It does not reduce the efficacy, but definitely reduces the side effects. Now, a common question that is asked for most from most patients is what are the common side effects. Now, there are thousands of side effects with chemotherapy, but the most common ones that we are concerned about is loose stools, because either of these regimens has got a 5-FU in their backbone, and 5-FU is a drug which is very notorious for causing loose stools, especially for those who have a mutation in their gene called DPD. It's an enzyme that degrades 5-FU. So if somebody has got a DPD mutation abnormality, the chances of side effects are much higher, that we usually test before giving the chemo. Neuropathy develops because of the other drug, that is oxaliplatin. Steatohepatitis is a very common feature, because after chemotherapy completion, whenever we ask the patient to go for the CT scan for checking whether is there anything inside, majority of the patients have fatty liver disease, which they did not have before chemotherapy. So unfortunately, oxaliplatin also causes a fatty deposition in the liver, and sometimes oxaliplatin-induced laryngeal dysesthesia. This usually happens when the patient is getting the chemotherapy, but that can be managed conservatively with warm air and avoiding cold beverages. So these 4 are the common side effects that we usually have. So till now I have discussed how we treat local or early colon cancer. We have to do the surgery, look at the staging in the pathology report. If it is a T3 early stage without any risk factors, no chemo required. If it is a advanced stage like node positive, you have to go for 6 months of chemotherapy. Now coming to stage 4, there is not much role of surgery. Mainstay is chemotherapy. Surgery is required in very few selected cases. Like, I'll give you an example. Suppose a patient has got a colonic mass and there are 2 liver metastases, which the surgeon feels, the GI surgeon feels that it can be taken out. In these situations, there is a role of surgery. But in extensive disease where there are multiple bilinear liver metastases or metastasis to other parts of the body like lung or bone, in those situations there is no role of surgery. Surgery only helps in reducing the intestinal obstruction if the patient has. Otherwise, there is no point going for surgery in stage 4 cases. Coming to median survival, now it also depends on a lot of other factors like which side of the colon cancer. Usually it's better to have a left side colon cancer because they live longer than the right sided tumors. Mutation status, some mutations like RAS and BRAF, if they are found, they have a very poor prognosis. Age, elderly have a worse outcome. Patients who have multiple comorbidities, they have a worse outcome because we cannot give the optimal treatment to these patients. And normally it can range from anywhere between 1.5 to 3 years for metastatic stage 4 colon cancers. Regimen, again the regimen is largely the same for adjuvant as well as metastatic. It is either a capox or a FOLFOX based regimen. Now with newer advances in targeted therapies, there can be some add-on therapies, like for right-sided tumors we can add bevacizumab with any of these regimens, and for left side we decide whether the patient has got a RAS mutation or not. If the RAS mutation is present, bevacizumab. If the RAS mutation is absent, then we add cetuximab. The combination of cetuximab plus chemotherapy has led to one of the highest survival rates of almost like 4 or 5 years. But for that, you need to have the patient RAS wild type and not mutated. Now coming to 2 slides on the latest advances in metastatic colorectal cancer. Immunotherapy, we all know that it is making its way into almost all cancers. Similarly, it has made its way into colon cancer. So there is this study called the Keynote study, where it was seen that compared to chemotherapy, that is either capox or FOLFOX, pembrolizumab, when given to patients who had stage 4 MSI high type of tumors, there is a significant improvement in the survival difference. Similar results was found in another study. This is a very latest article, so you can see February 1st, 2025 was the publication date. So another combination immunotherapy called nivolumab plus ipilimumab, which was compared with chemotherapy, and it was seen that there was improvement in the survival with nivolumab alone compared to chemotherapy. And the advantage of immunotherapy is that immunotherapy is not toxic like chemotherapy. It has got its own set of side effects which are mostly autoimmune, which can be managed with immune suppressants if they develop, but they do not have the damaging side effects of chemotherapy like neuropathy or mucositis or all those things. So if the patient has a MSI high cancer, immunotherapy is not applicable for all. You have to test for MSI. If the MSI is high, then only the immunotherapy works, otherwise it does not work. Now coming to another last targeted therapy advancement very recently. This is called a drug called trastuzumab deruxtecan. Now we all have heard of HER2. I have told in my previous slides that we need to test for HER2. Now why HER2 testing is needed? Because if the chemotherapy fails, we have the option of this drug, and this is called a waterfall plot where this was the baseline. So each bar represents one patient. So you can see majority of the patients had reduction in the tumor size compared to baseline. A small percentage did not respond. So there is a significantly high response rate to this drug. It is yet to come up as a phase 3 randomized trial, but this is going to be one of the important targeted therapies for colon cancer. Now I'll come to the last part, which is I think very important, extremely important, that is screening. Now this is applicable for healthy subjects. Obviously somebody who has developed colon cancer does not need screening, he is already developed. So it is important for us, healthy subjects sitting in this room. And there was a publication in 2025 February in South Asian Journal of Cancer, which is one of the largest journals in India in oncology. You see, highly educated medical community like this room, the real world utility was only 7% of the eligible population. So only 7% of the educated community goes for colon cancer screening, which is available at your doorstep. And if there are studies which have shown, large studies, population studies which have shown that colon cancer screening significantly reduces mortality at the global level, not just at the individual level. So what does the American College of Physicians recommend? Adults who are asymptomatic and has an average risk of developing colorectal cancer, like no prior diagnosis of colorectal cancer or polyps or IBD, no personal or family history. This is the subset where most of us would fall, like no family history, no IBD, no prior diagnosis of colorectal cancer. So for us, the recommendation is fecal immunohematological test, that is occult blood test, or DNA testing every 2 years, occult blood testing every 2 years, or colonoscopy every 10 years, or fecal testing every 10 plus a fecal immunotesting every 2 years. You can go for any one of them. If you are scared of a colonoscopy, you can go for fecal occult blood test, or you can go for the newer DNA based fecal tests which are available, which has got a sensitivity of almost 90 to 95% in detecting colorectal cancer. But definitely my suggestion to this learned crowd would be, if you fall in this category, which most of us fall, please do go for colorectal cancer screening, because if you detect early, there is a possibility that you will be cured in the long term. So my take home messages would be, we should all be aware of the symptoms of colorectal cancer. The mainstay of diagnosis is colonoscopy and biopsy. We need a scan for staging. We'll be having FAPI-PET in some time, which will have a very accurate staging of colorectal cancer. For early stage, the treatment is surgery followed by adjuvant chemotherapy. For advanced stage, it is mostly chemotherapy. We can add targeted therapies. If the patient is MSI high, we can add immunotherapy. And lastly but not least, screening should be utilized for every healthy adult individual above the age of 45 years. So this is the most important take-home message that I want to impress on to this learning audience. Thank you.
Hello. Thanks to Dr. Joydeep Ghosh for the nice delivery. So one question, do you suggest any anti-AR chemotherapy in stage 2 or 3 disease?
Sir, there has been a trial called Foxtrot trial, which has looked at whether anti-AR chemotherapy helps in advanced stage. Stage 2, no. Stage 2 test should be upfront. Stage 3, if it is unresectable, if it is locally extensive but not metastatic, in those situations you can give. And in some selected stage 3, which is very large, you can give, but it should not be the standard care.
Anti-AR chemotherapy followed by surgery.
Yes, sir, that is what I am saying, that most of the guidelines recommend upfront surgery followed by chemo rather than immunotherapy. For rectum, it is mostly anti-AR, but for colon, it is upfront.
Thank you. Any question from the audience?
Yes, I would like to know, because you mentioned specifically from disease or ulcerative colitis, they are not controlled. Many of the people we are finding IBS, irritable bowel syndrome,
Right.
they are also autoimmune disorder. Many of them taking up avasitinic or what do you advise regarding geriatric patients who are having IBS? Routinely they go to screening or any extra testing or different.
So if it is IBS, as such, IBS is not a risk factor for development of colon cancer. It is primarily IBD, but definitely it is indicated for all routine patients, as I showed in my slide. But IBS does not lead to colon cancer. It's not a risk factor. Yes. Yeah. So one common cause is that many patients take hematinics, so that is a problem. So nowadays there is this new DNA-based assay, which is more specific.
My father-in-law is an oncologist. So you are oncologist.
Yes, ma'am.
So I want to know the colon cancer or rectal cancer. If there is in both stages, in all the organs, lungs, your lecture is very good. I want to see because my father-in-law is a Dr. Sadhan Doctor is a oncologist. I know everything about oncologists, but because them, I mean, you know.
Thank you, very senior member, Dr. Dotto.
You laid emphasis on genetic aspect also in your presentation, but it's coming in a big way, not only for diagnosis but for investigation also for targeted therapy. Particularly Lynch syndrome, there are
Yes.
Lynch syndrome
Yes.
which are associated with different and ovarian cancers also. What about deficient MMR?
Yes.
You mentioned about MSI.
Yeah, that is basically deficient MMR.
Yeah.
Deficient MMR is basically MSI. The deficient MMR state leads to the microsatellite instability. So you can call it either MSI high or DMMR. Either way you call it, it's the same thing. So if we have an MSI high in a patient, you should also screen the patient for Lynch syndrome because they are very commonly MSI high.
Thank you, Dr. Ghosh, for your brilliant presentation in the most simplified way how it can be presented in an august audience. Everybody is happy, sir. Now I would like to invite our chairpersons, the felicitate Dr. Ghosh, and also I would like to ask Dr. Roy to join. Dr. Joydeep Ghosh is in Apollo's Physical Hospital. So if you need any help, he is always there to help you out. Very